Okay, well, it looks like we have a good number of people now, so I'll get started. So welcome to the FPMRS Fellows webinar series. This is a joint effort between AUGS, SUFU, and SGS, and we are grateful for their support in this endeavor. I'm Sarah Andiman, the third-year fellow at Mount Sinai, and I will be moderating today's webinar. Today's webinar is Surgery for Stress Urinary Incontinence, presented by Dr. Mickey Karram. Our panelists today include Dr. Roger Dmochowski from Vanderbilt and Dr. John Gebhart from the Mayo Clinic. The webinar will feature a presentation for about 30 minutes, at which time we will present some clinical cases for discussion between the panelists. We will open the webinar to questions from the audience for about the final 15 minutes. In case anyone here is watching for the first time, I'd like to briefly review some housekeeping items. This webinar is being recorded and live streamed. All participants will be on mute, but please use the Q&A feature of the Zoom webinar to ask any of the speakers questions. We will try to address as many as we can within the hour. Use the chat feature if you have any tech issues. AUG staff will be monitoring the chat and can assist. At the end of the webinar, you'll be prompted to complete a brief survey and provide feedback about the session. I also wanted to let everyone know that our next webinar is scheduled for Tuesday at 5 p.m. Eastern Time, and it's on neurology. It will be by neurourology, and will be by Dr. Stephen Krause. Please visit the AUGS website to sign up. This will be the last webinar of this series. All past webinars are available on the AUGS YouTube channel, as well as on the AUGS and SGS websites. And I will let Dr. Karram get started.
Okay, thanks so much, Sarah. I want to, let's see, how do I, all right, I can't get back to my screen here. There we go. Okay, so I want to thank Peter Rosenblatt for asking me to participate in this series. I've heard great things about it. I also want to thank Roger Dmochowski and John Gebhart for offering up their time to help me with this. So I'd like to go through a probably 20-25 minute didactic to review the literature around surgery for stress incontinence. And then I've received a bunch of very good questions that you've all submitted to Sarah that we'll address after that. So just to get started here. These are my financial disclosures. I'm going to start off by presenting a case, and I'd like to have you think about some things in this case. It's a case that could easily walk into any of your offices on any day. It's a 56-year-old who is about 1 year post-op from a single incision sling, synthetic sling. Her primary complaints are mixed incontinence, but predominantly in her mind, it's stress greater than urge. She is going through 3 pads a day. On examination, she has a pretty well-supported anterior vaginal wall. There is some urethral mobility. Urodynamics study, her subtracted CMG shows that she has a stable bladder to about 350 cc's. Her SUI is recurrent and is demonstrated at maximum capacity with a Valsalva leak point pressure of about 110. She has a normal PVR and really no voiding dysfunction. Cystoscopy is normal with nothing really significant as it relates to the case. So I want you to think about anything else you'd want in evaluating this patient. Would you insist on treating her OAB symptoms prior to surgery? What surgical procedure would you offer this patient if you were going to do surgery? And what would you do surgically with the previously placed single incision sling? So think about all those things, and we will come back to this case later in the presentation. So what I'd like to do is describe the surgical procedures that we have for SUI, both procedures that impact the bladder neck, as well as mid-urethral procedure. And then we'll quickly go through the literature. Hopefully you all will have access to this presentation, so I'm not going to spend a lot of time on the various slides that go through the various studies and analyses and Cochrane's on this, but we'll talk about cure rates, complications, advantages, and disadvantages of the various operations. So I know I'm probably preaching to the choir when I say this, but make sure you have the right diagnosis. And I don't say that lightly because in this day and age, you know, you as the specialist really need to be 100% clear that you're dealing with stress incontinence before you go to surgery. And always remember in the back of your mind that you should be able to reproduce at minimum the sign of stress incontinence 95% of the time in patients that you're going to operate on. But that's not the case, obviously, with detrusor compliance abnormalities, and that sometimes we're only as good as reproducing that with our testing 20 to 30% of the time. Obviously, quality of life situations, always talk about conservative therapy if the patient's interested. Is she a good surgical candidate? And patients that desire future fertility, I think, need to be treated in a unique fashion. Here's what the literature would show. We've got very, very good cure rates with everything from a colposuspension to synthetic slings to autologous pubovaginal slings. There's been a resurgence, obviously, with all the controversies around synthetic mesh with Birch colposuspension. This is an operation that John, Roger, and I did very, very commonly throughout the 90s. It can certainly be done via an open or a laparoscopic, and now there's numerous reports on doing it robotically as well. I do think this is still a viable surgery, and I think it's really important as you finish your fellowship, go to great lengths to get a little experience on doing this. It is, in my opinion, best done with a Birch modification or a colposuspension. It's simply placing a couple of stitches on each side of the proximal urethra and bladder neck. I don't get all caught up in this 2 centimeters lateral to the mid-urethra and 2 centimeters lateral to the bladder neck. It's more in the most pliable, movable part of the vagina, and sort of in the lateral part of that lower fornix of the retropubic space. You obviously want to get through the muscular part of the vagina. I like to bring both ends of the suture up through the ligament and tie them down. The tensioning is really in bringing the slack out of the suture. And I think if you do that, you've got good elevation, good success with hopefully minimal voiding dysfunction. You might consider this when you're doing other laparoscopic procedures or other open procedures. Young women who potentially desire future fertility, some would consider this a better option than a synthetic sling, although there's literature now to support a synthetic sling. And then patients come in and they just say, come hell or high water, they don't want a synthetic because they've either had one in prior or just is totally against it. Now, I have had patients come in like this. When I sit them down and talk about the various advantages of a synthetic and the significant lower amount of invasiveness, I've only had one patient in the last 5 years that still consistently insisted on having a Birch. Autologous fascial slings, most of those are going to be rectus fascia. Again, a very, very good procedure that's been done for a long time, excellent success. You're all familiar with the elbow study that showed it was more successful than a Birch colposuspension. More recently, I don't have the slide, Brubaker et al. Did a 5-year follow-up of this study and showed again that there was a bit of a deterioration in success in both groups, but the fascial sling was still more successful than the colposuspension. TVT, I'm using TVT throughout this presentation, but really I'm talking about any retropubic synthetic midurethral sling. I think they're all equal. So I'm not really implying that we're talking about the J&J product here, but TVT, as you're well aware, was initially described by Olmsted in Sweden, came to this country in 1998. There's a significant amount of data, which we'll quickly go through, but this is an operation that requires blind passage of a trocar through the retropubic space. And that to this day has significant morbidity, albeit very rare, but significant morbidity related to vascular injuries and bowel injuries. It's a great operation. It can even be performed under local anesthesia, short operating time. The tensioning is very, very loose, minimal anatomic distortion, which is a big advantage over a colposuspension. Colposuspensions, they antivert the vagina, and so you get rectoseals and enteroseals 15 to 20% of the time. I think it's a huge advantage that you don't get that anatomic distortion with the synthetic midurethral sling. And compared to traditional autologous bladder neck sling, it has much less voiding dysfunction. This is the original data that Olmsted presented in 1999, but what really brought this operation into the mainstay was the RCT by Ward and Stanton. This was done in 2002 and compared this to what was at the time considered the gold standard, and that was a Birch colposuspension. They had pretty strict criteria for success and failure, but their success rates were actually better in the synthetic sling procedure. So again, it's very, very important when you do, this is an operation that I am very hesitant to put these trocars in the hands of somebody that hasn't done a cadaver lab, and I'm not 100% sure that they have not, and unless I'm 100% sure that they have a good understanding of retropubic anatomy. You've got to really hug the bone and really appreciate the anatomic structures that are in close proximity. This is a laparoscopic view of the tip of a TVT needle coming through the urogenital diaphragm or the endopelvic fascia. Just to orient you, this is the right side of the patient. This is the right pelvic sidewall. This would be obturator internus muscle here. This would be the arcus here. This is the urethra and the bladder. Ideally, the tip of the needle should penetrate just inside the arcus and lateral to the urethra. I use a catheter guide. People who don't use that, I don't understand why. Olmsted nicely showed that you do get a deflection of a couple of millimeters of the urethra in the opposite direction, so it makes this space a little bit wider. And then you need to go to great lengths to hug the back of the bone, and the next, I like to almost feel that clear space as I penetrate, hug the back of the bone, and the next resistance you feel should be the bottom edge of the rectus muscle. This is some anatomic data that was published out of the Cleveland Clinic that basically shows that when you do this, you're well away from any vascular structures. But if there's cephalad migration of the needle, you're in close proximity to the obturator neurovascular bundle. And there's even been significant bleeding that occurs from the external iliac artery and even the femoral artery, which means it comes on the other side of the inguinal canal. As recently as about a year ago, there was a patient who exsanguinated from this procedure. So again, you have to be very, very clear about your anatomic structures that are in close proximity and go to great lengths to follow these anatomic landmarks when you do this procedure. So here's a couple of studies. This is a large, almost 1,500 patient study from Finland, 38 different hospitals. And again, you're going to see these numbers come up time and time again. Has a very, very low complication rate when done in experienced hands. But you will get some bleeding. We in our center had a significant hematoma in the last year. The patient did not require reoperation, but it was a big hematoma. So you always have to be cognizant of that. There's a lot of aberrant vessels that live in that space. Okay, we're going to switch to TOT procedures. These are sometimes better procedures in certain people's minds. They're more of a natural suspension. It's more of a hammock versus a U. Assuming you follow landmarks, it's a very safe passage. You avoid vascular bowel and bladder injury. Some people don't even think that you need to cystoscope. I would disagree with that. It's easy to learn and to teach. The landmarks are key here. The most important landmark is the tendon to the adductor longus. The lower edge of that was usually just across from the clitoris. You want to be very, very clear about the structures you're going through. The incision is a little bit bigger in my hands than that would be for a retropubic synthetic sling, because I want to be able to get my finger all the way up to the inferior pubic ramus. And if you're doing an outside in, you're going to be going through the very specific structures. You'll hear a first pop as you go through the gracilis tendon, then you'll go through the adductor brevis, the obturator externus, and then a second pop as you go through the obturator membrane, and then you hug the inferior pubic ramus and come out into the vaginal incision. When you get away from those structures, that's when you start to get issues with inner groin pain and leg pain. So it's easily passed. It has this type of trajectory. It's actually, in my opinion, tension very similar to a retropubic sling. And as I said, assuming you follow anatomic landmarks, it's very safe. You have outside in approaches and inside out approaches. I think they're relatively equal. The inside out approach has the potential for the exit point to be out laterally in the adductor magnus muscle, and you want to be careful of that. But other than that, they seem to be very, very safe. In general, similar rates of continence with probably less postoperative voiding dysfunction and irritative symptoms, and certainly fewer bladder perforations than you get with retropubic procedures. And here's some data. This is a study we were involved with that Matt Barber authored in the Green Journal, head-to-head comparison. And you can see that in non-ISD patients, they were equal. This is part of the Thomas trial. Same thing from Holly Richter. This is the meta-analysis that was done by Sung et al. And does show nicely that TO does seem to have less voiding dysfunction and less irritative bladder symptoms than you see with retropubic slings. Here are the complication rates. Surprisingly, they're very similar, except for the bladder injury rate is obviously much higher with retropubic slings. Surprisingly, in this analysis, leg complications were about the same in each group, and more voiding dysfunction with the retropubic slings. However, that's at the expense now in some studies that show less long-term durability with synthetic retropubic slings. You can see here again, less need for anticholinergics in the TOT groups. So outside in versus inside out, there's probably a little more thigh pain in the inside out. That's just my personal opinion because it comes out a little bit, and probably a little more higher possibility for vaginal perforations and pain at the distal anterior fornix for the outside in. So potential disadvantages of TOT, again, less mobility in ISD patients, probably have a lower cure rate, pain and infection in the genital urinary folds and thigh, transient weakness in the upper leg, rare cases of hysperunia from the sling sort of curling right underneath its exit point in the underneath the inferior pubic ramus. Here's some large studies. This is a large Kaiser trial looking at synthetic slings in general. And again, I underscore these large trials really just to point out how well these slings have been studied and how low the complication rates really are in these large series. This is a series of almost 4,000 patients done at Kaiser. Here's another very large series that was published in the American Journal in 2012. And again, you can see 9-year cumulative sling revision rate of only 3.7%. About 2.5% of those were for mesh erosions and about 1.3%. So these are really good numbers that you can share with your patients. Here's another study that, again, 10-year cumulative risk of sling revision, again, about 3%. It does show nicely that, and many of you, as you go out into practice, will be asked to sit on various committees at your hospital systems. And one of the things that comes up frequently is allowing generalists, and many of them are very appropriately trained in these procedures, in doing it. And this study nicely shows that there is a huge relationship between lower volume surgeons having higher complication rates versus surgeons that do these procedures more often. No difference in this study between gynecologists and urologists. All right, we're going to talk now about single incision slings. These have the least amount of data to date, but that is accumulating quickly. They have very, very good complication profiles. I think they're a very good option to treat patients that have occult SUI, and I use it in elderly patients that have milder or mixed stress incontinence symptoms when I'm correcting a prolapse as well. I do want to point out, this is going back to the Thomas trial. If you can do a single incision sling, there's definitely some advantages from an adverse event standpoint of not having an exit point. And this is nicely shown in this trial. You obviously get rid of any surgical site infection. You get rid of any potential for bladder injury almost 100% of the time. And you get rid of any weaknesses that occurred. So, you know, you add all these up and the vascular and neurologic symptoms that all occur by sort of exiting the pelvis and having an exit point either through the groin or in the suprapubic area. So you add all that up and you're close to 10% adverse event rate. So I'm a big proponent of single incision slings in the right setting. And as time hopefully goes on, there'll be more and more data to support their use. This is the Cochrane review on synthetic slings in general. And again, just to show that these large reviews again show that there's not a significant difference in TOT and TVT. This has been shown now in multiple studies. And it goes through the various things. Now, TO slings do have less voiding dysfunction, blood loss, bladder perforations, and shorter operating time, but more groin pain than you do with retropubics, as we saw before, and certainly vaginal exposure rates are about the same. They do show that retropubic bottom to top is more effective than top to bottom. And for that, I found that interesting. I wouldn't have guessed that that was the case. Inside out versus outside in and TOTs were similar. This is a National Institute for Health and Care excellent guidelines on incontinence. And they recommend first-line therapies to either be synthetic midurethral slings, open or laparoscopic retropubic urethropexies, or autologous slings. When offering synthetic devices, obviously you want to use devices that have proven data, that are macroporous, which all of them are, and you want to follow patients within 6 months to assess for any issues with the synthetic sling. So I'm going to quickly go through, as we finish up here, kind of the way I approach a variety of different things, and then we'll come back to our case. So if I have a primary SUI patient that's relatively young, that's got a hypermobile urethra, I'm going to always do a retropubic synthetic sling. If the patient, come hell or high water, didn't want a synthetic, it would be between a colposuspension or a autologous sling. Recurrent SUI with a hypermobility, assuming it wasn't a previous TVT, that's one of the questions we're going to come up with. I would go with a TVT, meaning if it was a single incision or transobturator, I would do a retropubic. I would never do a TOT after a failed retropubic. Mixed SUI, SUI with OAB, I'm going to most always go to a TOT or a single incision sling in those patients. Primary or recurrent SUI in a patient that's older with hypermobility, I think here you can again consider something along the lines of a TOT if you're concerned about voiding dysfunction, or even a single incision. A patient that has prolapse with outright incontinence, again, that's a little bit older, I'm going to do a TOT or a single incision. Recurrent SUI with hypermobility, in an older patient, I'm going to go with a TVT or rectus fascial sling. recurrent SUI with a fixed urethra, somebody that's had a colposuspension, an MMK, or has a highly elevated urethra, I'm going to bulk her. I'm never going to do something. I'm not a big proponent of a urethrolysis followed by another sling. Occult SUI during a prolapse repair, that's going to be a TOT or a single incision sling if I do anything. And then a recurrent SUI with a prior synthetic complication, with a request for not having a synthetic, I would do a pubovaginal sling almost all the time. So I urge you to really, really go to great lengths to understand this anatomy. Every chance you get, go to a cadaver, really understand the retropubic space and the inner groin anatomy, and that will be very beneficial to you when you're doing these procedures. So let's go back to this case real quick. There's a lot to think about here. And so I'm going to ask, let me start off with John. John, was there anything else you'd want to do on this this lady that we presented earlier on?
I don't have any further evaluation, Mickey. I think you've laid it out pretty good. I don't think she needs anything further from my standpoint.
So what would you, if she did want to go ahead with surgery, what would you do on her?
I would do a retropubic midurethral sling would be my preference in this patient. Having failed a single incision, which is sort of a version of a Transobturator in my view. So I would do a retropubic approach.
I agree with that. What would you do? So would you go after the synthetic sling, and what would you do if you ran into it?
So I would do my dissection for the retropubic approach. If it was in my way, I would cut it and take that segment out. If it's not in my way, which often it isn't, surprisingly, then I'd just go ahead and leave it alone and place the retropubic. There's some reason it failed. You have to ask yourself that. Was it didn't anchor well, it wasn't tensioned well, or it isn't where it should be, would be the most common things I would think of. And often it's not where it should be. And so it may not be in the space you want to occupy with your next approach. So if it isn't there, I just leave it alone.
Great. I agree with that. Roger, anything you want to add on this case?
No, I agree with John's plan and strategy completely. I would say one thing, Mickey, that I would like to document in this individual is if there's any point tenderness over the sling. I do think that's important to document in the world of litigation and mesh. And then the only other difference is that I would offer her either the alternative of a retropubic midurethral or a pubovaginal sling.
Sure. And I think that's an important point. I think you've got, you know, she's had a synthetic and it's failed. And John brings up a good point. You don't know exactly why it's failed, but something didn't go right, obviously. And she's got some mobility, and most of the time these slings are going to be a little more proximal than where you would place a retropubic synthetic sling. So I think you can, you know, assuming there's no issues with it, it's not tender, it's not exposed, it's obviously not in the urethra. No reason to go fishing around for it. So now, one thing that does jump out at me with this case is that you just want to make sure she's going through 3 pads a day, and the stress incontinence that you demonstrated was not extremely severe. Now, again, that correlation is difficult to be exact, but you know, while you're waiting with this patient to get her scheduled, I don't have any problem trying her on a little antimuscarinic or merbetric or for a short period of time. I doubt that there's, you know, this is a weird presentation of an overactive bladder. She was stable to 350 cc's. But again, keep that in the back of your mind. Avoiding diary might be helpful as well. I wouldn't delay much here, but I don't think it's unreasonable to play around with some things while you're waiting to get her scheduled. I don't have anything else to add besides, in addition to what John and Roger said. So we're going to go ahead now and go. Sarah was kind enough to advance to us multiple questions, very good questions, by the way, that we're going to go through. So I'm going to take the first set of them and then let Roger and John comment, and then we'll kind of alternate. So the first one is under a category of surgical planning. First question is, what do you do in the case of a TVT sling failure? So very good question, because that's kind of our go-to operation with synthetic slings. So personally, she needs a full evaluation, obviously, with a urodynamic and cystoscopic. And if all of that is pretty straightforward, she just has recurrent stress. I go to great lengths to determine if the TVT was done appropriately and is in an appropriate place. So if it's, I know the way I do it, if it's my TVT sling failure, I'm gonna sort of not try. I'm not a proponent of putting a synthetic sling over another synthetic sling. And I know the way I did it. If it failed, I'm gonna abandon the mid-urethra and recommend this patient have a rectus fascia autologous pubovaginal sling. And that's just because I really can't understand why. Our success rates are very good, but we all have failures. So that's kind of the way I would handle that. Now, if it's somebody else's and I look and I can feel that this thing is at the bladder neck, is not in an appropriate position, then I would consider another retropubic synthetic sling. How do you manage SUI in a patient with, well, let me ask John and Roger on that. So how do you guys, Roger, what do you do with a failed synthetic retropubic sling?
Yeah, I think John's point about why did it fail is critical. And I think you really have to ask yourself that question, and whatever you need to do to get to that answer. I personally, especially if this patient is coming from outside, will want to do a workup of the lower urinary tract. I do think this is an indication for urodynamics and cystoscopy. Mickey mentioned this. I want to underscore the importance of cystoscopy as part of these procedures. Even a well-placed or apparently well-placed sling can go in places that we don't want it to. And I think we have to appreciate the value of cystoscopy, and both John and Mickey and I will remember the not too distant past when there was this sort of flippant, oh, you don't need to scope patients. And we learned the hard way that was a terrible piece of advice. So not that that's going on with this individual, but I think you need to do the minimal data set that you need to answer the question. And if that includes urodynamics and cystoscopy, which it does for me in this circumstance, I would clearly do that. But Mickey's points are very important. The sling may be too loose. It could be that it's placed too proximally, although I think that's less of a reason for failure. It's often a point for obstruction. Or has there been some other misadventure that's led to sling malfunction? John, what do you think?
I would, emphasize excellent points, Roger. If it was a non-retropubic and it was placed at the time of a prolapse repair, say a cystocele repair, even if they did separate incisions, I've seen times where it's almost proximal, it's under the trigone almost, and that's why it wasn't working. So I think the workup is really important, and emphasize Roger's point on cysto, because even though she may not have symptoms, I would like to know if there's a problem in the bladder before I get to the OR. And then recognize it at that point.
Okay, great. Next question is, how do you manage SUI in a patient with prior sling revisions who now has SUI? So this is obviously a patient that has had some sort of an erosion or misadventure of some sort. And that could even be, the sling being in the urethra or whatever. So again, you have to sit and talk to the patient. She's had a synthetic with a bad outcome. And many of these patients really are not crazy about having another synthetic. If that synthetic misadventure was actually something that, that ended up in the urethra, I'd be somewhat hesitant to go to another synthetic, even if it's been a while. At that point in time, that's a good indication for me to use autologous tissue. But it really depends on what the patient wants. You kind of talk to her about, what happened. And if I think there's a high likelihood of it happening again with another synthetic, I'm going to avoid that. John, Roger, anything to add on that?
I don't have anything further, Mick.
Okay.
If I may, we have a few questions around that topic that are coming in. First, in the cases of TVT failure, one question was, does anyone plicate the existing piece of mesh as an attempt to correct? And then what are your thoughts on using cadaveric fascial slings instead of, I guess, rectus fascia slings?
So I've heard of this plication. I've never done it. I don't know if, so basically what they're asking is you open up and you actually plicate the mesh across the midline. I've never done that. Have you, John or Roger, do either of you have experience with that?
Heard of it, Mickey, but never done it myself. And it doesn't really make much sense to me because you're plicating mesh to mesh, and you wouldn't expect the mesh to self-adhere. So I would,
especially if it's been a while. Yeah, it's hard for me. John, have you had any experience with that by any chance?
Have not.
Okay. And then what was the other question, Sarah?
On the other question, we had a couple of questions about if anyone has experience with cadaveric fascial slings, and if I know there's, maybe not a lot out there, but does anyone use those or have experience?
Yeah, so I years ago, I used to use cadaveric fasciolata that came from a tissue bank in Dayton, but we weren't getting good tissue consistently. I'm sorry, it was cadaveric fasciolata. So I abandoned that and went to copy our own rectus fascia. Recently, I have now had a fair amount of experience by a product that's commercially available from Coloplast called Suspend, and it's cadaveric fasciolata that is very consistent. It comes from a company called RTI, which is the big producer of biologics for a lot of the orthopedic stuff. So I have had some experience with that, and it's all been very good. But in general, I think you have to be very, very careful on where it's coming from. Anything else on that, Sarah, or should we keep moving with your question list?
No, I think we can keep moving for now, and I'll insert some more as they come in as we go. Okay.
Last question on surgical planning. Do you use a different product or different surgical technique in obese and morbidly obese patients? So that's a really good question. So and again, we're talking about a morbidly obese patient, somebody who has a huge pannus, very, very large thighs. That's a situation where I've used single incision slings and really tightened them more than I would normally tighten them. And now I'm talking, a handful of cases. But it can be very, very challenging when you have very large patients to pass slings retropubically or even transobturator wise. So in that morbidly obese patient, I have used single incision slings. But I'd be curious to hear John and Roger's thoughts on that.
John?
I like a retropubic sling. You would almost think they're going to need the most, so to speak, based on their body habitus. I can think of a handful of patients that it was hard to grab the needle tip retropubically because of the mons. You actually had to make a slightly bigger incision there to get it. But the other thing I'd just warn people is it would be easy to get prepubic if you weren't paying attention in a morbidly obese patient. So pay attention if you're going to do a retropubic sling.
Good, very good point. And you can do the same thing with transobturator as well. You got to be very careful that you can get around the bone. I think that's a great point. Raj, anything to add to that?
Well, I agree with every. Actually, I've done both. I've done retropubic suspensions. I've done autologous slings on these patients, and I've done single incisions like Mickey has. I think, though, in really significantly obese patients, it is. I think it's good practice to at least have a discussion about the patient's motivation about weight loss, because weight loss clearly is beneficial to the patient. And I have seen some dramatic improvements in incontinence with either medical and or surgical obesity management. And I think you should at least have that discussion with your patient. I mean, there are some people who say, I'm not going to touch you unless you lose X. I don't think that's fair either. But I think in this day and age of information, we have some very good level 1 evidence data that suggests that weight reduction is very beneficial, not only for outlet, but also for storage symptomatology. And it should be considered if the individual has any degree of motivation as part of a health maintenance strategy.
Sure, that's a great point. Okay, John, we're going to go on. I don't know if you've got these in front of you, but I can read them to you. I'll have you take, this is intraoperative complications.
Sure.
I'll read them. I'll read them to you. The first one is, how do you manage bladder perforation?
Yeah, first is you have to recognize it, just an absolute. So cysto there again is absolutely critical. If you recognize the perforation, you'd remove it. Let's say it's unilateral, you'd remove it on that side. I would put drain the bladder, put the catheter guide back in, just sort of reset and restart would be the first thing. I'd also say, the perforation's the easy thing to recognize. I'd also look to know that you're not too close, that you're within the bladder wall or something. That's actually something that you could miss much easier than the perforation, and both can be problematic. I don't think there's really a need to drain the bladder if you perforate it. In my experience, on a retropubic is going to be most likely, because it's in a dome area, it's in a non-dependent area. Most trocars are probably 3 millimeters, 4 now. I don't think you need to put a catheter in afterwards. You certainly can if you want to, but that's how I'd approach that.
So yeah, I agree totally. And you bring a good point about the needle being in the wall. You really like to move that needle back and forth and see that it's really outside the bladder, that it's creating these little indentations in the bladder, but you can roll the needle on the bladder and you can nicely see it. If the bladder wall is moving with the trocar, you should remove it and repass it. And some of these perforations can be pretty small. So you be very, you got to really expand the bladder and make sure you see it.
Roger had a comment, Mickey.
Okay.
Yeah, I think it's important also, we use the term perforation a little bit loosely. And I think all of us have seen injuries that are not just a puncture, they're true laceration. And at some point you have to make in the moment judgment about the adequacy of letting that, if you will, be versus a formal repair. And if you have more than just a perforation, and that perforation is especially on the inferior aspect of the bladder, I think you really need to consider doing a formal repair, especially if you're going to try to put mesh over that. And I would caution you that if you've had a significant injury, and it is let's say if you think of the bladder neck as an o'clock face, and it's somewhere between the 3 and 9 o'clock positions, but you need to be cautious about thinking about putting a piece of mesh on that. And certainly if you have a needle perforation of the urethra, be very cautious about putting mesh over a freshly perforated urethra.
Well, I'll go a bit farther than that, Roger, because I think John and I were looking at this from the typical, 1 to 3 o'clock on the left and 9 to 11 o'clock. But you bring up a good point. If you have a urethrotomy or you get into the bladder very low in a dominant portion, and there's any way that that sling is going to be in close proximity to that even after you repair it, I think that's a clear indication to abort the procedure. I'd be very reluctant to put a synthetic over an area that you just repaired. I don't know what you guys think about that.
Agreed. Absolutely
yeah,
agreed.
Yeah. Okay, John, your next question is, you do your dissection and you're getting a lot of bleeding. You're seeing a pretty heavy amount of bleeding coming from the two tracks that you've created, either before or even after you've passed the trocars and the sling.
Yeah, so a couple things. One, let's assume we've done a good technique, that you showed some good illustrations, that we haven't let our tip wander on us and we're not out in some major vessel somewhere. So we're going to set that aside, but you're doing a good technique and you get different bleeding. So recognize what you're seeing. How much do you usually see? And is this something different than that? That's sort of the thing that ought to make the bell go off for you. Most of the time, and let's say it's a retropubic sling, it's going to be the paravesical veins that are going to want to bleed on you. And you showed a nice CT picture of a nice hematoma in the retropubic space, and I have my same pictures of those. If you do enough, you're going to get one. But remember, you're only seeing part of the bleeding, because that, let's say you did a retropubic sling, part of that's going to be filling up that retropubic space potentially. That can hold a lot of blood, so you want to be thinking about that. I would start with just manual pressure, both suprapubic and transvaginal or suburethral, however you want to view it, and sandwich that area between my hands and hold that for 5 minutes, 10 minutes. If you knew you had a good bleed, that's one thing I've done previously. I might even, if I knew I wasn't in the bladder, I would go ahead and tension it, or at least get it ready to tension and then hold pressure. Because if I'm going to alter it, I could stir up bleeding again. So I might even want to get it where I want it and then hold pressure. You could fill a Foley balloon fuller with more fluid and pull it towards the bladder neck to tamponade that area potentially. You might need, I think most Foley balloons might hold 30 cc's. You might fill it or get a bigger balloon that you could put in to pull down and tamponade it, are some things that I've seen. Or even injecting a hemostatic agent up through your incision, in through the urogenital diaphragm into the retropubic space. I don't have any affiliation with hemostatic agents, but if I was going to choose one there, I'd use Flow Seal, because it's got a nice little applicator that would get you up into that space. I would never use cautery. You'd be blindly doing a radio frequency ablation instead of burning anything there. It just wouldn't probably be a good choice.
Yeah, I think all of those are really, really great options. I agree. You don't want to just blindly cauterize up there. The key is pressure. It's kind of a double-edged sword, because you've got a lot of bleeding, and you should, make a note in your head that she's bleeding a lot, meaning, you're going to watch this lady in the postoperative period. The lady that exsanguinated that I mentioned during my presentation was watched only for about an hour in the PACU and was let go home. She lived a long way from the hospital. I think she was discharged around 1 p.m. and around 5:30, she passed out on her bathroom floor, and nobody found her until it was around 7. And then by the time she got to the ER, they had no idea that she had even had a sling, because it was out in the country, et cetera, et cetera. So somebody that you're concerned about, watch them a little longer, check a post-op H&H. The flip side of that is, obviously, you never want to jump to a laparotomy or extreme amounts of concern with this. The pressure, 95% of the time, takes care of it. And again, if you're concerned a bit, maybe even pack the vagina for a short period of time, and just monitor them postoperatively. Roger, you have anything else to add on that?
Well, two things. One is, and John said this very succinctly and eloquently, but I think, especially if you're, again, as a urologist, I'm a top-down person. Many people who use TVT are bottom-up people with their trocars. I think you really have to be extremely assiduous about the placement of your trocars, because if you have a good deal of lateral and outward rotation of your trocar, you are very close to not only obturator but larger femoral and pelvic vessels that can result in exsanguination, and in fact have. So be aware of that. Both myself and one of my partners, young in our careers, experienced significant retropubic bleeding that actually did require an opening of the pelvis to control. And interesting enough, in retropubic space, there's enough venous anomaly and venous variation that you can hit a venous vessel the size of your small finger. Yeah, maybe sometimes pressure helps those. Most of the time it does, but I've lived through that, and I've seen, again, a very experienced partner go through this. So there are vessels that have no names other than the retropubic, excuse me, the urethral venous complex, posturethral complex, that can have significant issues related to bleeding. And don't forget, there are also venules that live at the base of the bladder that can also have substantial bleeding. But John's points about blind coagulation, for that matter, blind suture play, sometimes you end up causing more trouble than you get.
Before we get off this topic, I just want to bring up one more question related to bleeding. What about bleeding at the perforation site in the bladder if you were to have a perforation that you discover on cystoscopy? Would anyone ever use electrocautery there? Would it necessitate a bladder repair, in some cases by urology? What are your thoughts on that?
So I've had my share of bladder perforations. I think I'm right in the mix of, about 2%, 3% maybe. And I've never, ever seen one that required anything, but I'll defer to Roger. Would you go in with a boogie and cauterize that, Roger, if need be?
Mickey, I've never experienced it either. And as you said, I've had my share of perforations too. I can see, though, in the realm of reality how it could occur, because there are people who have relatively more vascularity in their bladders than others, just in terms of propensity scoring for the distribution of vessels. And I could see how it would occur. And yes, I would just simply take a scope, get adequate localization, and use a bug bee, which is essentially a roller ball type device, and place it directly on the perforation and treat it as if you had taken a biopsy from the site. But again, I've never experienced that, but I can see in the world of reality, I can see how it could occur.
Great. John, the last part of this set of questions, have you ever been in a situation where you had to abort a retropubic procedure because you kept hitting the bladder? And the question is actually, after how many bladder perforations would you abort a procedure? And I think John's probably the best person in the country to answer that, because he lives in a place where a lot of Marshall-Marchetti-Krantz procedures were done. And of course, we all know that those never fail, right?
That's right.
But, back in the day, they even used to do cystopexy. So do you have any experience where you couldn't get through the retropubic space without hitting the bladder?
Thanks, Mickey. And that's a critical point. So history, and Roger mentioned it earlier as well. So if they've had a prior retropubic procedure of some sort, they're more and you're doing a retropubic approach on them, you're much more likely to be in the bladder or deal with it. And so keep that in mind. I've seen, I can think of a patient straight off where had a retropubic procedure. I think the fellow, we had 4 holes in the bladder. I think we perforated both sides on once and then again and again on another. And then I sat down and we were able to navigate it. But I think we did put a catheter in her just to play it safe because it wasn't one hole. But there is a point, and you should define that for yourself in advance if you felt uncomfortable when you should stop in a setting like that. And certainly, I think Roger made an excellent point. If you've got a laceration versus a perforation, you really ought to think about needing to fix that and abandoning it.
Yeah. Yeah. I think that's, I've had two on one side and one on the other side, and we did finally navigate through, but I think that the bottom line is, when you're at a point where you're uncomfortable, you're starting to get a lot of hematuria because you've hit it a few times. It's just not worth it. I think you abandon the procedure and kind of rethink things and bring them back at another time. All right, let's keep moving. The next set that I'm going to have Roger take these. These are postoperative complications, Roger. The first one is, in what circumstance do you send a patient home with a catheter after a sling? What can you quickly go through your sort of routine? We'll assume they're just having a sling. How do you manage that? And
Sure. I basically what I would do was avoiding trial when at the time, expected time of discharge. The pubovaginals go home the next morning. The midurethral obviously would go home that afternoon. If there has been concern regarding integrity of the bladder, I have no issues with sending the patient home with a short-term catheter management plan. Obviously, if there's extensive repair, then you need to plan for a reasonable period of time for the bladder to anneal itself back together, which I usually say is, and most studies would suggest, is 7 days.
yeah, Roger, do you think there's any role with just routine incontinence surgery for suprapubic catheters?
No, I do not.
Yeah, I don't either. John, do you still use suprapubics at all?
Do not anymore. Started that back in '02, but don't do that anymore.
Yeah, I think we're all in agreement with that. Just transurethral Foley. If they go home with a catheter, Roger, do you give them prophylactic antibiotics?
I do not.
Okay, John?
No.
No, we don't either. If a patient is unable to, we already said that. Okay, so I'll start with Roger, but all of us will take this. So you've got a, we'll just say it's a synthetic retropubic sling. She goes home with a catheter, and she comes back in a week, still can't urinate at all. You teach her how to self-cath, which she's fine with for a while. And she's still not voiding, or if she is voiding, it's very little, and she's going through various acrobatics, leaning back, standing up, and you assume that she's obstructed. When would, Roger, we'll start with you. When would you consider doing something to the sling, either loosening it or cutting it?
I mean, if you're going to try to loosen a sling, you pretty much have got to do it within the first 2 weeks. About after that, in my experience, is things get annealed in. Cutting's a little bit different. I mean, you can cut a sling at any time. Obviously, it gets a little bit easier, harder to do rather the longer you wait. But loosening clearly has to be done relatively early. And if the patient is miserable and in retention, I would do that within the first 2 weeks.
John?
I agree completely with Roger.
Yeah.
Yep.
Yeah, that's a really good point. Because there's complete tissue integration. Early on, we noted this. When you get much beyond 14 days, the sling is pretty much integrated in the tissue, and you can't really significantly alter it without cutting it. And the problem is, if you cut it, your chance of recurrent SUI is going to be a lot higher. So I agree totally with Roger. I think you want to go in within the first couple of weeks, try and get a right angle clamp between the sling and the urethra, and we just basically kind of stretch it and loosen that up, and then close the incision back up, and that's worked well for us. Okay, next set.
I'm so sorry. It looks like we're running out of time. We're running a bit over, so I think we're going to have to cut it short. Although we do have some other excellent questions that I'm sorry we can't get to. I do want to thank Dr. Karram as well as Dr. Gebhart and Dr. Dmochowski for their excellent information. It was a great discussion. We answered so many questions that have come from the audience and the fellows. I'd like to once again thank AUGS, SUFU, and SGS for putting together these informative webinars. And just a reminder that these webinars will be on the website of AUGS, SGS, as well as the AUGS YouTube channel for those who'd like to join in on this great educational experience. The next webinar will be next week, June 16th at 5 p.m. Eastern Time on neurourology, and we look forward to seeing you then. If you cannot watch the live broadcast, you can also watch the archived version on the Society's websites, as mentioned. Stay well, and we'll see you next time. Thanks.
Thank you. Thanks, everybody.